Hello, everyone, and welcome to week 7. This week, we're going to talk about assessing risk. And I do want to let you know that this is an introduction to this topic. We'll be covering this more in the trauma and crisis class that you'll have later on in the curriculum. So our agenda today is to do an introduction of the topic. Then we're going to get into more specifics. We're going to talk about self-harm, suicide risk, and relational violence. All right, so these are some things that I want you to keep in mind as we go through all of the materials today on these different topics. I also wanted to point out that crises, and again, we'll get a definition of that a little bit later, but a crisis is often a time that assessment is very important. And these are the 3 kind of steps that you want to think about to make sure that you take care of in times of crisis. So the first thing is to have a plan. Know what assessments you or your workplace use to assess any of the 3 topics we're going to go over today, and keep them in a handy place. So that could mean having them printed out. It could mean having them pinned to your desktop or in a folder for these types of specific assessments. However, you always want to have a plan so you know how to access the assessment that you want to use during that time. The second thing that you want to make sure you always do is follow the assessment. You want to follow both the guidelines and the flow. This is not a time to sort of do your own thing, and we'll get to the why of that in just a moment. However, it is definitely in the best interest of your client and for you as the counselor to closely follow the assessment. And then finally, you want to document that you did the assessment and consult about it if you do find that you need to consult someone. So after you complete the assessment and make recommendations to your client, you want to go back into the client notes and write about what you did. So you would say, I used the SLAP assessment to assess suicidal ideation in client. I found suicidal ideation was low, therefore we created a safety plan, and the client has agreed to allow me to call them in 2 days to check in and see if things are better or worse, and make ongoing decisions from there. So something like that. And this documentation is so important, 1, because it's ethical to do so, and 2, because if something does happen, it shows what steps you followed, and also shows that you did follow things according to the plan. You used the assessment correctly. You knew how to use the assessment. It's an assessment you're familiar with. Therefore, your results and the decisions that you make after that all depend upon the things that you've already done well. So we're going to begin by talking about self-harm. And when we talk about self-harm, we generally do not mean suicidal ideation or attempts at suicide. What we're talking about are things that happen when a person hurts themselves, most of the time without suicidal ideation. So this could be things like cutting, it could be things like burning oneself or banging your head against the wall. So they can be quite dangerous, and they can have implications that could lead towards serious harm or death. But it is also important to not make assumptions based on myths around self-harm. And so sometimes people will say they're doing it for attention, or, if they were really serious about hurting themselves, they do it a different way. Things like that are not helpful for clients or for practitioners either. So really lead with empathy and compassion into the assessment process and the interventions that you choose. And please know that someone who's been self-harming has been probably doing that for a while, especially if they have significant scarring or if they've been in treatment for that. And so you are not going to help them fix the issues within a short period of time. Much like many other complex aspects of mental health, self-harm is a coping mechanism that at one point probably worked pretty well for the client, but got out of control and is at usually the point of intervention harming them more than helping them cope. So it is really important to be patient with yourself and with your client, and for both of you to understand that you are going to come from a strengths-based and compassion-based viewpoint when you're making the treatment plan, and you both also understand that there is no quick fix. And if you're working with teenagers, you want to relay that same information to their parents. So here is one way that you can assess for self-harm. So the first will be informal, and I give you some questions in this chart that you might want to make note of. Tell me about when you hurt yourself. How long has this been going on? How often do you hurt yourself? So things that you want to assess sort of the severity and history of the concern. And so you'll see the rest of the questions there. And then our chart points us to screening for suicidal ideation. So you may have answered that in your previous questions, but I think it's important to go back and say, are you having thoughts of killing yourself? Very, very plainly, you're going to probably practice a lot saying, are you going to kill yourself? Are you thinking about killing yourself? Because if you ask a question like, are you thinking about harming yourself? Well, you're already assessing this person for self-harm, so it's likely that they are, but that's not necessarily the same thing as suicidal ideation. So the actual tool that we're going to learn for suicidal ideation today is called the SLAP, and that would be a quick way to measure it if you feel like you need to document more information on, is this self-harm or is it suicidal ideation? So for the sake of the chart, what we're going to do is say, okay, no, the self-harm for this client is not suicidal ideation. That's been clear through the questions and the informal assessment and performing the SLAP. So we would move into a more formal assessment for self-injury. And once again, you want to choose an assessment you're comfortable with and that meets the cultural and developmental needs of the client. So for instance, you wouldn't want to choose an assessment that was normed on middle-aged white men if your client is a young Black woman, because you won't know if it's culturally appropriate if it hasn't been normed on that. And then you also want to think about the developmental needs of the client. So what is maybe their reading level or comprehension level? Is English a first or second language for them? And so factors like that will help you choose the right assessment for your client. And then if you will look in the resources section in your Canvas, you'll see that there are some resources for formal assessments for self-harm there. And then finally, so you would complete the assessment, follow the guidelines, and then using that and sharing it with your client in a very person-centered, caring, empathic way, sharing the results, and then collaborating together to create a treatment plan that includes ongoing assessment of the self-harm. And that would include things like severity, how often it's happening, are they able to use some of the other coping skills that they're learning in counseling, etc. So you could also go back to your informal questions and kind of make sure you ask a series of those every session to check in on where they are with the self-harm behaviors. Another thing that you could do that would be helpful with informal assessment would be scaling questions. So you are asking some other quantifiable questions about how often do you hurt yourself, but you could ask on a scale of 1 to 10, how much have you wanted to hurt yourself this week? And then on a scale of 1 to 10, how often have you been able to not do that? So kind of looking for strengths, looking for progress. So we're going to move from that into suicidal ideation and talk about some of the risk factors and some ways to attend to and treat this. Again, this is an introduction. We're going to cover suicidal ideation, assessment, and treatment pretty thoroughly in the trauma and crisis class later on. But some of the risk factors are previous attempts, chronic pain, a family history of suicide, recent release from prison or jail, and you can read through these: depression, substance abuse, And it's important to remember that it's not just one of these things, but it's often multiple factors that can increase or decrease suicidal ideation. It's very much dependent on the person. So these are all factors that you should assess for in your intake through informal questioning and conversation. And then if you need to follow up later about more of that, you can ask more detailed questions or use a formal assessment. So one thing to remember is that as a mental health professional, we always take it seriously if someone expresses suicidal ideation. We do not go back to what people may say, like, they're looking for attention, or they say this all the time, or they're just dramatic. We take it seriously. And if you have a parent or someone else that's involved in care of your client who doesn't take it seriously, it's probably important to do some psychoeducation with them on suicide risk factors, and other indicators to help them understand why we take it seriously. So if suicidal ideation is indicated in any way, you want to do a formal assessment. You want to document your results and always consult. Before you begin an assessment, like if you're hearing something from your client that indicates that either sort of straightforwardly or reading in between the lines that they are thinking about killing themselves, you do want to stop the conversation and say very frankly, have you or are you thinking of killing yourself? And direct language really matters. I know it can be scary sometimes to use that kind of language, but when you use phrases that kind of soften it, such as hurting yourself, or even ending things, it can feel like the client has permission to answer it in less of a direct way. So when you're direct with them, they're likely to be direct back with you. So this is the SLAP assessment. Again, there is a PDF of this slide in your Canvas material, so it's easy for you to access. SLAP stands for specificity, lethality, availability, and proximity. And the objectives listed here for each of those items, and also some sample questions that you can use. So for specificity, how specific is the plan? Do they have a plan, and how specific is it? So you could simply ask them, do you have a plan to kill yourself? And if they say yes, then say, what is it, or tell me about it, etc. And the more specific the plan it is, we know the more that they've been thinking about it. So in your mind, that should move the risk factor up. Lethality is how lethal is the means to which the client plans to complete suicide. And so again, you can go back to the question about the plan. They may have already mentioned a means, but if not, you can ask them, have you thought about how you would kill yourself? And we know that lethality, has a lot to do with the means that are used. Almost all suicides that are completed with a firearm are deadly. Sometimes if a client or a person uses something like pills or even cutting the wrist, it may not be as lethal as a gunshot. However, that doesn't mean you shouldn't take it seriously. And that leads us to the next question, availability. How available are the means that they plan to use? So if they say that it is a gun, do they have access to a gun? How would they get a gun? If it is pills, same question, like, do you have pills? Do you have access to pills, etc.? And then proximity. So this is how we're looking for how close people are to help them if they do become actively suicidal outside of session. Who can you call for support? Who is close by? As a counselor, unless you are working on a crisis setting and a crisis line, you aren't going to be the immediate person that's available. Oftentimes counselors will have answering services after hours, or if it's during the day, you may be in a session or doing something else. And so helping the client identify who they can call or who will be nearby can be really helpful. And then I listed a few more follow-up questions at the bottom for you to help you work through this assessment. I'm gonna go back for just a moment. So you complete this assessment and then you document that you did the assessment. You make a plan with your client based on the outcome of the assessment. So how serious is this? And again, this assessment is formal, but it does not have a scoring system. And so even if you wanted to add, 1 to 5 ratings and kind of rate their answers on each one, you could do that, or you could just look at your notes. And if they have, pretty detailed answers for most of these questions, especially the first 3, you are probably going to want to take that threat more seriously and then follow up on that more seriously. I do really want to stress also the importance of consulting. So especially in your early years, there are just so many people available to help you. And so that's going to mean your instructor in the program. It's going to mean your site supervisor, your peers. When you graduate and you're in a licensure supervision, you will also have a supervisor that you can call. You'll probably be practicing with other people. So if there are other clinicians nearby, consulting with those can be really helpful as well. So don't feel like you are ever alone. And at the end of this presentation, I actually put in kind of a little bonus on safety planning. So we'll come to that in a few moments. All right, so our last topic on assessment of crises is relational violence. And oftentimes relational violence is referred to as IPV or intimate partner violence. You may have also heard it referred to as domestic violence, and that term is actually more associated with the criminal justice system because that would, in a lot of places, be what someone would be charged with. But within mental health and mental health treatment, the term intimate partner violence is more common. And we know that IPV affects almost 12 million people a year, which is so many people. We also know that females that are in relationships where IPV is present are more likely to be murdered by a firearm than any other means combined. So again, like having a firearm in the house is risky. I know that many people take precautions to keep firearms in safe places. However, if you have someone who is already leaning towards violence, it's much easier for them to access a firearm if it's in the house. So I think that's kind of where that statistic comes in. When you're assessing for risk clients affected by IPV, you're assessing for homicide risk. So how likely are they to be killed by their partner? At what level is their risk? And of course, it is important to remember that violent behavior in the past is a predictor of it in the future, but that doesn't mean that always happens. There are other indicators of past behaviors that can be predictors, such as, controlling in multiple means, partners dictating what the other partner can wear, where they can go, who they can talk to, things like that. So there are other predictors, but violence in any way is definitely one of them. And then finally, duty to warn implications. So state laws vary around duty to warn and what's allowed and what is not allowed, but generally for most states, duty to warn means if someone in your office is going to kill themselves or is going to kill somebody else, actively planning to, or is in active harm of being killed, you have a duty to warn either the person that is at risk, or I notify the law enforcement officials so that they can help the person who is at risk. So this is a threat level assessment that you can use as well for this to, when you're listening to your client's stories about incidents of IPV. So you'll listen and then you want to assess for the wording of the threat, the level of premeditation, and the realistic indicators. And kind of for each of these categories, you can see over in the chart what I have listed as a threat level, low, medium, and high. So vague, going from vague to very direct and specific. And And then as far as the level of information goes, is it kind of inconsistent all the way up to like steps have been taken to prepare? That's especially important if you have a client who is planning to kill their partner or indicating that they may want to kill their partner or somebody else that's close to them. It could be their boss, it could be a friend, etc. And then realism, is the person kind of blowing off steam? Does it lack realism? I think oftentimes that happens with clients. Or are there a lot of realistic indicators, like they've already talked about what time and place they can do that? So all of these factors are important to listen for, and just remember that the more details there are, the more well thought out something is, then it's a higher threat level. And then again, I have at the bottom, always consult and document, because this is serious stuff. And so making sure that you've gotten other opinions, making sure that you document everything you use to assess for these types of situations, and sort of your own, even an ethical decision-making model could be helpful in this instance. Really important for both your safety and the client's. So what happens when you assess for any of these types of risk? First, you're going to share the results with the client because they should know that you're doing the assessment. It's important to tell them that and tell them that you take, seriously any type of harm, whether it's self-harm, IPV, homicide, or suicide. So you're doing the assessment, you share the results with them in a very caring and empathic way. Make sure they are also reminded of and clear on the limits to confidentiality, because those come into play a lot at this point. Make a collaborative plan, and sometimes, actually I would say most of the time, that works really well, making a collaborative plan. There are times where a client maybe scores pretty high on a suicidal ideation assessment. However, they don't want to, drive themselves to the ER, or they don't want to be admitted to a local facility or something. And in that case, you may have to do an involuntary admission. But hopefully that will not happen too often. In my experience, it's pretty rare that something like that happens. So you make a plan, hopefully it's collaborative. You consult with your supervisor now or literally anytime, especially if the client is not wanting to help or be collaborative on a plan to keep themselves safe and it's an extreme kind of level of danger. Bring that supervisor in as soon as possible. However, if they score a little bit lower, what you can do is make that plan, share resources with them, the National Suicide Hotline, any kind of local crisis hotlines, treat a plan for what they can do when they start feeling overwhelmed, and then you're going to document all of that. After the client leaves, you are going to follow your side of whatever plan you came up with, which should include regular sessions, checking in, and reassessing whatever type of harm or risk assessment you've just done. So I have a little case study here for you, and I'm hoping that you will pause the presentation after I go through it and answer some of these questions. And I think it will help you with your other assignments in the class this week as well. So Brian is a 45-year-old male in counseling for anger issues. He discloses to you that he hates his supervisor at work and wishes Bill, who is the supervisor, were dead. Brian is also having relational problems with his partner and often takes his angers out at home. You ask if he has thought of killing Bill, or if his anger ever gets to the point that the safety of Brian's partner is threatened. Brian responds that he does think about killing Bill and that he has a gun at home. However, he says that he only contemplates killing Bill when he is intoxicated. Brian also states that he does not want to hurt his partner, but he has hit and pushed when angry. He follows this up by stating that the thought of hurting his partner makes him want to put the gun to his own head. So here are some questions for you to consider. What types of threat are indicated, and what level of threats are indicated? What other information do you need to assess the threats? If you determine the supervisor is in danger, what are your next steps? If you determine Brian's partner is in danger, what are your next steps? And what are your next steps with Brian? So lots of big questions around a complicated case. However, I think it is also important to point out that clients are complicated. And so oftentimes they'll come in with one presenting issue, but once you kind of start the therapeutic process, you see that just like every other person, clients are like an onion, and there's layers and layers and layers that you have to peel away. So I'm gonna assume that you have paused and worked through the previous case study before you turn me back on for us to go over safety plans. So again, this isn't something that I was going to cover, would regularly cover just for assessment. However, I know a lot of times students are curious about, well, what do I do after? You know, how do I help the client, or how do I move them forward? And safety plans are often what is used now with clients who do not need a hospitalization, either voluntary or involuntary. It is important to note that safety plans are not no harm contracts, but a way to help clients help themselves. Contracts were used in the past pretty frequently between counselors and clients when they were facing some sort of risk. However, contracts were found to be largely like the client just didn't care about them. It wasn't particularly helpful, and it didn't keep them from acting through on a threat, because essentially a contract would just say, I promise my counselor I'm not going to do this. And so in that way, contracts aren't super helpful at giving the client resources or coping skills or other things that they need in the moment of crisis. So here are some guiding questions you can use to build a safety plan, and there are also examples in the Canvas module for this week. So these are things you would ask the client and then document in some way so that they have it with them. What are my warning signs that I'm starting to feel? Insert whatever you just assessed risk for. What can I do to help myself? So this will be what they do now that works well. It could be new coping skills that you've talked about together. So this would be a good time to brainstorm. Who can I contact to distract me? Distraction is helpful. And so sometimes it doesn't have to be, you know, a big intervention. It could just be like a 20-minute phone conversation with a friend. Who can I contact to help me? So if things do get a little bit worse past this, and I need someone to come to my house or sit with me, or I need to go somewhere, who can I contact? What resources are there if I don't want to call my friends or family? And then where do I need to go to get away from what I may harm myself with? And this is a tricky question, because some people, you know, it's common household items that they would use. It could be scissors, it could be knives, it could be lighters. And so, you know, really thinking through that and having a plan that relies, you know, on external forces, leaving a space, etc. Because taking a knife and putting it in a drawer doesn't actually get it away from the client. So I know that was a very heavy, lots of topics that are difficult to work through, and many times we have friends or family or acquaintances, people in our social circles that have dealt with those sorts of struggles. Unfortunately, it is all too common, which is why it's so very important that all mental health professionals are ready to assess and treat these concerns. So I know this has been a hard week of content. I hope that you are proud of yourself for getting through it, or if you're still getting through it, be proud of yourself that you're working on it, and take some time for yourself. And that is all I have for you today. Thanks so much.